What's going on?
Well, Benjamin, it's nice to meet you. It's a pleasure to be part of your podcast. Who is Eric Smith? Well, I am a former board certified OBGYN who happened to stumble upon cannabis about 6 years ago. I used to help women who had addiction and help them get access to cannabis, sort of to help them sort of kick the opioid habit. Um, Most people don't know that cannabis does help in addiction, particularly with opioids. And so that started my career in cannabis. And so I've been supporting a telehealth company that has been helping people get access to cannabis. I help educate people on cannabis and medical treatments with cannabis. I'm really excited right now that cannabis will hopefully move into a different realm of scheduling, which will allow us to actually go through research and support patients in actual clinical trials related to cannabis. And it's something that I'm really excited about from the cannabis space.
Hmm.
Um, Throughout the course of my career as an OBGYN, I have done a lot of different things. I have done aesthetic medicine, I have done executive medicine, I've done international medicine, I've done rural medicine, I have supported hormone therapy, I have done work as a laborist, so sort of getting out of the traditional OBGYN office space, kind of hang out in the hospital primarily. Did that for a number of years. And so the latest thing that I've been doing related to the cannabis space is my company, which I've been leading as a medical director. We got into hormone therapy, weight loss, things that I have experience with in the past to kind of help patients with the 21st century things. Patients are seeing a reduction in their hormones, testosterone, estrogen, progesterone, as well as people want to lose weight. And so the new GLPs have been on the market and have been gangbusters. And so we got into that space as well to support patients. And we've been doing peptide therapy as well to kind of help patients in that realm. Um, in terms of my life and my life's work, um, I have been married twice, and both of my marriages have ended in divorce. And it dawned on me that what exactly is causing this for me. And of course, there's a lot of collateral damage to that that's beyond just divorce. I have children that are involved, and I have children who have alienated from their protective targeted parent. Um, and I wanted to understand how to end uh, generational trauma related to divorce, but
Mm.
also more importantly, find a way to to allow people to not experience the same trauma that I have gone through. And so that's the reason why I have started a company called TaxWise. And
Hmm.
TaxWise is my life's work. It is um, it is very dear to me, and for the past, I would say, 10 months, I have been trying to understand attachment theories, um, personality types, understanding instinctual variance, understanding other types of trauma-based issues that lead to attachment disorders, and trying to find a way how to be able to help people consciously choose partners as opposed to subconsciously. So
Mm.
that's really what my life's work is now. So yeah, that's me in a nutshell. It's not all of me,
Yeah,
but
it's a lot,
Mhm.
definitely. Like that's, I guess, four companies, if I'm correct.
Yeah. So I manage. as a medical director for a parent company. It's called Veramed Tech. Um, we
Hmm.
have uh, we have two companies that are under that umbrella, Dose Pop and Veriheal.
Very hill.
And then my company, Attachwise, is so it's three companies really.
And I have to say, I really, I know I'm a marketing guy myself. I really like Dose Pop's 70s aesthetic. Our company, Caesar Health, this is the Caesar Health podcast. And we really
Mhm.
tried to, on our end, like we have all this like Roman stuff. You can look at our Instagram if you want, but we really thought
Mhm.
like, how do we stand out when everyone just looks the same? And I can see Dose Pop definitely did that with this kind of 70s aesthetic.
Well, my
I get it.
CEOs they are young, energetic, guys. They obviously started a cannabis company, and so they wanted to bring fun back into healthcare,
Yeah.
and that was their thought process, and pushing Dose Pop with that 70s look in a way to kind of make it fun. And that has been a game changer in terms of the concept within the office and the practice.
And pivoting when I was looking at Veraheel, am I saying that right?
Yeah, very hill.
Veraheel.
Mhm.
The mission statement really caught my attention because it was like shame-free healthcare, and I was wondering if you
Hmm.
could elaborate on that more.
Well, cannabis is considered to be taboo. It's improved a great deal since we started the company in 2018. But what but the idea though is that it's still considered to be taboo. In many circles, cannabis is considered to be a gateway drug. And so when we talk about shame free, the idea of it is that we don't want people to get a card or have access to cannabis or discuss it with the idea that there's some shame involved in using a plant that people, that really the name marijuana has been has been used in a way to not only the criminalization of cannabis, but also in terms of marginalization of people
Mm,
related to cannabis. And so and so we've been seeing a tremendous evolution as we got into medical cannabis, as we see it in our society with more recreational cannabis, and that's something that's very hard for me as a physician because cannabis is a has been around for thousands of years as a medicinal agent, and it has been in the pharmacopoeia. Back in the early turn of the century, I'm talking about in the 1900s, it was in the pharmacopoeia. So it was certainly something that was used as a medical treatment. I mean, even the I think Queen Victoria, used to use cannabis to help her with her menstrual cycles, which were
mm.
which were epic
I didn't know that.
back in the day. So the use of cannabis is something that has been used for years as a medicinal agent, prior to it being in the 1930s, where it was bastardized, lack of a better term, and also stripped from its medicinal use from the pharmacopoeia. So at that time, it came out of favor as being used, and the pharmaceutical industry started to bring into to treatment its own modalities. I mean, Bayer with aspirin was one of the first drugs that hit the market that was used and that took the place of cannabis as a pain medication.
Mm,
Um, and so as we see recreational use increase throughout the United States, we are also seeing sort of the pull, or I should say the push, really, from the medical cannabis um, industry in terms of what I do in terms of making sure patients have not only have access but also helping them to treat certain ailments with cannabis therapy.
mm. And I should have done more research on this before this call. I didn't realize we'd be speaking so much about cannabis necessarily, but like, what is the legality of cannabis in America? Is I know it's legal in some states.
Hmm.
What's the future of cannabis in America? Like generally
Hmm.
speaking, from your perspective.
So cannabis is so in 1971, actually 1972, I believe is the year. Richard Nixon um, formed a coalition to look at drugs and marijuana, not cannabis. It wasn't called that. It has been called that. It has been called cannabis for a long time, but at the time it was considered to be marijuana.
Yeah, it sounds
Marijuana
scarier.
was, yeah, it was. Um, and the spelling is kind of weird. It has changed over the years, but marijuana was pushed into a category with heroin and other types, LSD, to a Schedule One uh, drug. So that means that it's something that you cannot purchase from a pharmacy. You can't get it. It's considered to be a drug that is restricted, unlike cocaine, which cocaine is a Schedule Two drug, with other pharmaceuticals like opioids, like Percocet, Percodan, things like that are Schedule Two. So the Schedule One put it into a category where it's federally illegal, meaning that you cannot use cannabis in a federally. And therefore, there are also restrictions federally with cannabis, meaning that you cannot use federal funds to fund anything that touches cannabis, okay? Which is one of the big issues that the cannabis industry has, because it has to report taxes differently. It can't get
Mm,
funding specifically from banks. It has to be done by different types of organizations that are outside of the traditional FDIC banking components. So that this is one of the reasons why the moving to Schedule 3 will be a tremendous boom for the cannabis industry,
mm,
that it will allow for companies that are touching cannabis to be able to get funding from banks. It will allow them to also be able to file taxes differently, and make business tax concessions and different types of things that normal businesses do that they can't do with touching the cannabis plant. So you asked about throughout the country, the United States. So when California was the first state that 1996, I believe, was a year, the first state that allowed for cannabis to be used medicinally. Okay, and what happened was that the federal government turned their eye to it and said, okay, if you want to use cannabis as a medicinal agent. At the time, it was very helpful. We saw it during the AIDS epidemic, um, and we saw a tremendous amount of use with that. 1996, finally, cannabis was able to be used as in a state acquired medical cannabis program, and that was the first one. And since that time, we've had about 38 states who have come to develop some form of a cannabis program. Um, Most states are medicinal, and there are some states that are medicinal and recreational. You see more and more states have gone recreational. There are a few states like Virginia that is recreational, but they also want you to have a cannabis card. So that's a little bit odd. They actually are having some legislation now to go full recreational, so that will change things for them. But the state of cannabis in this country is that it's still federally restricted. With its movement to Schedule 3 will change that tremendously. So that
mm,
will allow for, as I mentioned, the restriction in terms of Schedule 1, it'll allow for research to take place. In the United States, there was only one company, or not really company, one academic center that was allowed to use cannabis for research purposes. And that meant that even anyone who's doing research related to cannabis in the United States, they could only get their product from that specific academic center.
mm,
That hopefully will shift and change and now allow for other academic institutions to be able to create funding and research, and to really develop some great protocols for treatment with medical cannabis. So that's the case. Just to add a couple other context to cannabis. Um, Most people don't know this, but you're not supposed to go across state lines because it's a state product. So people who
mhm,
often say you live on the border of, like, Pennsylvania, which is a medical state, but and not a recreational state, and you want to get cannabis somewhere, well, you got to travel. So you go to either New Jersey, which has a recreational program, Maryland, recreational program, Delaware. So you go to these states to buy product, and then you go across state lines back to your house with your cannabis, and that's against the law. And most police officers aren't pull you over unless you actually, you imbibing or using it in your car or whatever. And that may not be a problem unless you're doing it while you're driving. You can drive impaired, and that could be a problem, obviously. Um, and so those are some of that's to answer your question in terms of the United States, the state of what cannabis is in the U.S.
So then tying that back into the operations, like like your patients, like where like are these all patients in Pennsylvania or and you're just running in Pennsylvania and just helping sort of local people in the state, sounds like.
So I'm licensed in 12 states, and I help patients with cannabis and about right now I'm in 8 states. I support
Okay.
cannabis in 8 states. And I had to kind of think about it because there's some states that I have a medical cannabis um, where I have a license in that state, but I don't necessarily offer cannabis due to a lot of administrative reasons. Some states require DEA licensure, and
Hmm.
sometimes it's an extra cost. It's also difficult to obtain a DEA in every state because you have to have a physical address in that state that will allow you to be able to prescribe um, I would say scheduled, let's call it scheduled medications. Even though cannabis is not scheduled, some states want you to have a DEA to be able to prescribe, or not prescribe, but to recommend. Because we don't prescribe cannabis, we recommend it because since it's a Schedule One
That's
drug, you
interesting.
can't prescribe it. You recommend it.
We recommend it. Okay.
Yes.
It's interesting.
Yes. hmm
Yeah, this is not really something I know that much about. It's but I in the I think it was Warren Buffett who famously said, you know, if you're going to start a business, you want like a moat. I think for you, the amount of regulation kind of is a moat. Like if you're going to run this business, you know, legally in the United States, there's just so much stuff you have to deal with. It takes
hmm
like the champion to say like, you know, I'm going to deal with it and I'm going to create this company in however many states you want to roll with.
Yeah, so as far as with that, we're not plant touching, so we don't have the same restrictions that companies who are cannabis, um, who are plant touching cannabis programs. So people who are farmers, people who are um, packagers, distributors of cannabis, obviously retail people who are also um, in dispensaries. Those are places where they're plant touching, and that becomes a problem for
Mm.
them.
So, so as long as you're not touching the plant, you can kind of
You can,
ease off a
yeah,
bit.
exactly. hmm
I, I want to pivot and ask about your telehealth operations. And you know, without
hmm
getting too political, I know that the Medicare for telehealth has been extended, but it's kind of, you know, on the, you know, on the fence. We don't know what's going to happen with it. Like, what's your thoughts on, you know, telehealth and the future of telehealth in America? It's maybe a chance for you to vent a little bit.
So telehealth really came to power, I would say, during COVID. We realized the power of telehealth during COVID and realized that we can do a lot of things um, via the via that modality. And so with that, um, with that. I believe that the concessions that were made during the course of COVID were utilized to be able to allow for physicians and other types of healthcare providers to use the telehealth platform to help support their patients. Um, and and so today I believe that some of those, so there are some restrictions that have dropped. So Florida is a state that dropped the telehealth services after COVID was over. So they looked at it after 3 or 4 years and said, "Hey, we're done with this." But I think telehealth is here to stay, and
Mm,
the reason why is because we have realized that we can. we can actually deliver services to patients, throughout across the country, in different areas, as long as the doctor is, and I'm just talking about pure medical, telehealth. As long as the doctor is licensed in that state, you can be able to deliver those services. So there are a lot of physicians in the United States who are licensed in all 50 states, to offer services, medical services,
Hmm.
and wherever, throughout the country. I would say that there are some things and some nuances that I miss, without seeing, without seeing patients in person. And some of those are actually, seeing the health status of your patient, looking at their skin, evaluating it, looking in their eyes, understanding, that you can gain a lot more information from a patient if you put your hands on them. So telehealth takes that away. It makes us focus in a two-dimensional way, looking at a patient and being able to address their issues, and then, of course, giving them something, some type of treatment, and that could be even more watered down in terms of medicine. I mean, today, a doctor, even if they have, a time frame, 15, 20 minutes to see a patient in the office, they may not necessarily stop to put their hands on the patient. That really has changed medicine significantly. I'm from the old school where you see patients and you examine them. And I believe that's really something that, is really the best part of medicine, because there are times when you may notice something, like, a patient comes in for a routine, prescription visit, and, you examine it. They may say, "Hey doc, I have this lump in my neck," and lo and behold, they got, stage 4 cancer. And these are things that we miss when we do telehealth.
Yeah. We had a guy on here called Nick, I think last month, and his startup, what they were doing was they were actually like training. If you wanted to, you could get a diploma in urology as a nurse practitioner, and then
Hmm.
you could practice urology as a nurse practitioner. But then in their startup, they had, a doctor who had, the actual urology diploma that you would work with. So it was interesting. Like it was a rural health solution, but it was kind of interesting. It was seeing kind of telehealth mixed with the traditional technology. I thought it was a cool solution.
Yeah, that's a great solution. And it just speaks to the idea that we want, we need those types of ways to improve, patient care with using, mid-level providers. That really helps a great deal. Having mid-level providers to support, the entire infrastructure of the medical treatment program.
Yeah. The podcast has a kind of an AI theme to it. I mean, where our company does do AI for medical clinic administration. It's what our bread and butter is. Do you use AI at all? Or do you have any interesting
Mm-hmm.
AI at the clinic? What's going on?
Yeah, I use AI. AI is sort of my friend, my foe. Now I love AI. My TouchWise company, is an AI focused company. What AI can do, is something that humans can't do, and that's the whole idea of using AI to support the personality, the attachment, the sexual variant assessment. AI can look at patients, clients, and you look at their responses and be able to tell you more information, and also use that to correlate, with other patients and clients that they have seen previously, to sort of have a great makeup. Part of what I have developed with my AttachWise program is to be able to utilize personality type assessment, instinctual variant assessment, attachment assessment, and using voice base. So using voice, that voice is so critical because with voice, they can pick up on some nuances as patients answer the questions to be able to determine their personality typing, instinctual variant typing, and their actual attachment. So from that standpoint, AI can help predict based upon personality and attachment if there are risks to, um, not only the attachment disorders but risk to mental health. So these are things that we're able to see, and that's one of the things I want to validate with AI as we continue to push forward. Um, as we sort of push forward um, um, the attach wise assessment. So I want to be able to do that. So that's my big thing with AI. Beyond that, I use AI. Really, I've learned a great deal in terms of prompts. It helps me write letters and helps to look over my thought process related to related to letter writing and things like that. I ask it tons of questions that help support me in terms of some of my medical decision making. It
Mhm.
teaches me things about certain types of products and different information that is really supportive. I've done a great deal of supporting it with giving it some of my own thought process that it utilizes to help me make decisions that I forget things. So it's sort of like one of the things about medicine is that you most of the times you see the same things over and over again, but there are times when you don't. And by some of the interesting cases I developed and I put into to my AI system, it's it's amazing that it will draw upon that to sort of help me figure out certain issues. It thinks of things that I don't remember about, certain types of interactions with drugs. It will it is definitely a friend that really sort, and I don't want to call it a friend because it really is. It's a colleague
Mm.
that really helps to support the way in which I practice medicine.
Yeah.
And
And what we're doing at Caesar Health is like this all these AI agents we're building, like that's exactly what it is. Like it's like it
hmm
will, check make sure that your notes are correct for clinical documentation, AI
hmm
secretary to make sure that nothing goes to voicemail, they can book them
hmm
in. So I totally feel you. I mean, I think that's
hmm
really in line with what we're doing here at
hmm
Caesar Health as well.
Yeah, absolutely.
Yeah. So if people want to find you, Eric, like where, should they follow your LinkedIn? Where can they, reach out to you?
Yeah, my LinkedIn profile is probably the best place to find me in terms of reaching out regarding all the things that I'm engaged in. I would say soon my website is coming up for AttachWise. I've been working on that for the last few months. Just really trying to figure out the best way to push that forward. So AttachWise, the actual company will be launching its website probably at the end of this month, and that's really a good place to find me there. But also part of my other work with Very Hill, I lead that medical division, and it's you can find me at Very Hill. We are the largest medical cannabis and education company in the U.S., and we support over 400,000 patients. Um, and we've lost some patients with the recreational component, but we're eager to bring patients back to really foster a stronger educational program and hopefully as we start to increase with research, we'll be able to have better understanding of how we can support patients with cannabis. That would be tremendous if we can do that. And I really the whole idea of it, our whole goal is really beyond the um, I call it shame informed. Or the uninformed shame patient, but the shame that's associated with cannabis. We want to be able to say, hey, we are able to then to not only support you with cannabis and the education, but also to destigmatize cannabis, but more importantly, to show what it really can do. And so you can find me there with Very Hill as well.
Awesome. Okay. Thank you so much. I really enjoyed it.